Okay, so let's jump into something pretty interesting today, huh? Aortic stenosis.
Oh,
We're going deep on this one.
yeah, you bet.
And, you sent over some pretty detailed cardiology notes. I had a chance to look them over, plus some follow-up questions.
Yeah.
And I think our goal today should be to really kind of break down this condition
Absolutely.
to understand, the key signs we're looking for. How can we tell if it's really serious or not?
Yeah.
Um, what else could it be? What are some other things that we might, uh, need to think about? And then, of course, how do we manage this? So this is going to be like your express lane
Right.
to a pretty clear, insightful understanding of aortic stenosis,
Mm.
drawing directly from the medical details that you've provided.
Perfect. Yeah, and what you've provided is a real clinical snapshot, which is fantastic.
Right.
And we can kind of go through these notes carefully and really tease out the important points that are needed to really understand the intricacies of this fairly common but quite significant heart valve problem.
Okay, so let's start with the very beginning here, the initial picture of this patient,
Sure.
an elderly man. And he's presenting with, signs that point towards aortic stenosis.
Yep.
So as we're looking at those initial, those physical exam findings, what immediately jumps out as something that's, pretty important?
Well, I think there are a couple of bits of information that are really important right at the beginning. So the fact that he's in rate-controlled atrial fibrillation is an important kind of backdrop, especially in an older individual, because
Right.
AF gets more common with age
Right.
and often is an accompaniment to valve problems as well.
Right.
And then straight away it says low volume pulse.
Right.
And that should really, set alarm bells ringing, potentially, that there's some sort of blockage of blood flow out of the heart.
Okay.
His JVP, his jugular venous pressure is normal, and his apex beats normal. And that suggests that, at least at this point in time, there aren't really obvious signs of heart failure or any kind of, significant fluid overload on the right side of the heart.
Okay. Okay. And then, of course, we get to what, a lot of people would consider like the hallmark
Yeah,
of aortic stenosis, and that is the heart murmur, right?
absolutely.
So it's described here as being high-pitched and loud,
Yep.
audible throughout the precordium, but loudest over the aortic area.
Right.
And then, really importantly, radiating to the carotids
Yes.
in the neck.
That radiation seems like a pretty specific clue, doesn't it?
It really is. I mean, that carotid radiation is kind of the fingerprint, if you like, of aortic stenosis, because that turbulent rush of blood trying to get through that narrowed valve
Right.
is so forceful that it creates vibration.
Wow.
And you can actually feel and hear that going up into the neck arteries.
Yeah, yeah.
So that's a really, really important kind of distinguishing feature.
Right. And also the fact that it says the second heart sound is quiet. That's another important part of the jigsaw here, which kind of hints at the severity, which I'm sure we'll delve into in a minute.
Okay, yeah, let's talk about that now, those indicators of potential severity.
Sure.
So specifically, they mentioned that quiet second heart sound, the long duration of the murmur, and then that low volume pulse that we already talked about.
Right.
So
Yeah.
why do those three things in particular, really strongly suggest that we're dealing with a more significant narrowing of the aortic valve?
Well, it's fascinating because all those things that you've mentioned are kind of indirect measures of how much obstruction there is.
Oh, yeah.
So, for example, that quiet second heart sound,
Yeah.
well, you can imagine the aortic valve like two doors slamming shut.
Okay.
And if those doors are very heavily calcified and stiff,
Mm-hmm.
they're not going to close with the same sort of crispness and force.
Right.
And as a result, you get this much softer, quieter sound.
Yeah.
So that quiet S2 can be a direct reflection of how much that valve has physically stiffened up.
I see.
And then, the longer the murmur during systole, that means the heart's taking longer to eject blood
Okay.
through that narrowed opening.
Right.
And you can think of it like trying to empty a bottle through a tiny spout.
Right.
It just takes longer, doesn't it?
Right.
And then that low volume pulse is a direct consequence of the heart struggling to pump an adequate amount of blood through the restricted valve. And that leads to this weaker pulse
Okay.
that you
Yeah.
feel in the arms and the wrists.
Yeah, no, that makes total sense.
Mm.
So then they also mentioned the absence of a forceful apex beat.
Yeah.
And they kind of present that as something that doesn't really quite fit with the idea of severe stenosis.
Right.
So why would that be? I mean, if things are really backed up.
Yeah, this is an interesting point because it reflects on how the heart adapts
Why?
to a chronic pressure overload. So, in aortic stenosis, the left ventricle often thickens up, and this is a process called hypertrophy.
Hmm.
And it does this in order to generate enough force to push the blood through that narrowed valve.
Okay.
And sometimes that thickened muscle can create a stronger, more forceful apex beat
Okay.
that you can feel on the chest.
Right.
Now, the fact that it's not there doesn't
Huh?
necessarily mean that there isn't severe stenosis, particularly, if we're talking about an older patient
Okay.
who might not be quite as robust
Right.
or whose heart muscle might not have mounted such a vigorous hypertrophic
I
response.
see. I see.
So again, it just reminds us that we have to look at the whole clinical picture, not just one finding in isolation,
Right.
and that further testing, objective testing is vital.
Okay, so that leads us to the next step, right?
Yeah.
Which is further investigation with an ECG
Right.
and really importantly, an echocardiogram.
Absolutely.
So what key pieces of information are we hoping to get
Yeah.
from those two tests?
So the ECG can give us some clues as to whether the left ventricle is thickened, whether there are any other rhythm problems besides the atrial fibrillation, and
Uh-huh.
sometimes even hints of, reduced blood flow to the heart muscle itself.
Okay.
But really, the gold standard here is the echocardiogram.
Okay.
Think of it like an ultrasound for the heart.
Okay.
And it allows us to actually see the aortic valve,
Okay.
measure how much it opens, which is the valve area,
Right.
which in this case is very important, at 0.9 centimeters squared.
Right.
And it allows us to work out the pressure difference or the gradient across the valve
Okay.
and assess how well the left ventricle is actually pumping overall.
Right.
And the fact that it mentions that there's good left ventricular function, that's a really important bit of information
Right.
when we're thinking about treatment options later on.
Got it. Okay, so we've looked at the initial presentation.
Yeah.
We've looked at those indicators of severity.
Right.
Now let's consider, what else could be responsible for
Hmm.
that ejection systolic murmur that we're hearing.
Sure.
So the notes list, aortic stenosis itself, aortic sclerosis, and hypertrophic obstructive cardiomyopathy as the main, possibilities.
Right.
So how do we begin to kind of distinguish between those three things just based on that initial physical exam?
Well, this is where the subtle details of the murmur and other associated findings really come into play.
Okay.
So aortic sclerosis is essentially a thickening and calcification of the aortic valve,
Okay.
but it doesn't actually significantly obstruct blood flow.
Okay.
And the murmur in sclerosis is usually softer, it's shorter, and it's less likely to radiate strongly to the carotids
Oh,
compared to true aortic stenosis.
got it.
Now, hypertrophic obstructive cardiomyopathy, HOCM for short,
Right.
this is a condition where the heart muscle itself, particularly the wall between the ventricles, thickens up, and it can actually obstruct blood flow out of the left ventricle.
Okay.
The murmur in HOCM can be quite variable, and often it gets louder with maneuvers that actually decrease the amount of blood in the heart.
Oh, okay.
Like, for example, standing up suddenly or
Sure.
doing a Valsalva maneuver, which is the opposite of what you might expect with aortic stenosis.
Okay, so it sounds like, the timing of the murmur, the location on the chest where we hear it best,
Yes.
and then where it radiates to, those are kind of the key things
Absolutely. Yeah.
that we're looking at.
Yeah. Spot on.
Okay?
Yeah.
And then they also touch on pansystolic murmurs,
Yes.
like mitral regurgitation,
Yeah.
and explain why those are less likely in this case as well. So again, it seems like the timing and the location and that radiation are really important there too.
Absolutely. So in mitral regurgitation, where you've got that leak of blood going backwards from the left ventricle into the left atrium, during systole, that produces a murmur, which starts right with the first heart sound
Okay.
and continues all the way through to the second heart sound.
Right.
And it's typically loudest at the apex,
Okay.
which is the bottom tip of the heart,
Mm-hmm.
and radiates towards the armpit.
Right.
So very different location and radiation pattern to what we're seeing here,
Right.
where the murmur is loudest over the aortic area and
Right.
traveling up to the neck.
Yeah.
So although, the sound of aortic stenosis can sometimes be heard all over the chest, that strong upwards radiation to the carotids is a really crucial, localizing sign.
Yeah. Okay. And then there's the question of pulmonary stenosis, right?
Yeah.
again, location of the murmur on the chest being highlighted as a really big difference.
Yeah. So pulmonary stenosis, which is the narrowing of the valve between the right ventricle and the pulmonary artery,
Uh-huh.
that would be loudest over the pulmonary area, which is typically higher, and to the left of the aortic area on the chest. And it also mentions here that you might expect to feel a right ventricular heave,
Right.
which is a lift or a thrust that you feel on the chest because of an enlarged right ventricle
Okay.
in pulmonary stenosis, and that wasn't noted in this patient.
Right.
And also, pulmonary stenosis is more common in younger individuals,
Okay.
whereas aortic stenosis is more prevalent as we get older
Okay.
because of that age-related calcification process.
Got it. Got it. Okay. And then there's this subtle point about, how these murmurs change with breathing, right?
Yeah.
So pulmonary stenosis tends to get louder when someone breathes in.
Yeah.
What about aortic stenosis?
Yeah, so it's all to do with how respiration affects the blood flow
Yeah.
through the different sides of the heart.
Okay.
So when you breathe in, you get an increase in blood flow going back to the right side of the heart.
Right.
And that can make right-sided murmurs like pulmonary stenosis more obvious.
Okay.
Now, aortic stenosis is a left-sided murmur.
Okay.
And during exhalation, there's generally a bit more blood returning to the left side of the heart.
Okay.
So you might find that the aortic stenosis murmur is a little bit louder
Got it.
during that phase of breathing.
Makes sense. Okay, so we've got the echo
Yeah,
confirming severe aortic stenosis.
right.
We know the patient is symptomatic. They're feeling breathless.
Yep.
And then the notes really emphasize the importance of getting a good detailed history about any other symptoms.
Yes.
So why is that so critical at this stage?
Well, this brings us on to the bigger picture of managing aortic stenosis. Because the presence of symptoms
Yeah.
in somebody who's got severe disease is really a major trigger
Okay.
for considering intervention,
All right.
usually in the form of an aortic valve replacement.
Right, right.
And the classic triad of symptoms that we worry about are angina, which is chest pain
Okay.
related to reduced blood flow to the heart muscle,
Right.
syncope, which is fainting, often due to a drop in blood pressure when the heart can't keep up. And then heart failure symptoms, like the breathlessness that this patient's already experiencing.
Right.
So if any of those symptoms develop
Yeah.
in the context of confirmed severe aortic stenosis,
Right.
then it means that, the condition is really likely to be impacting on the patient's quality of life
Right.
and also potentially their prognosis.
Wiggle.
So it makes intervention much more, urgent.
Okay, so while we're considering those potential surgical options,
Yeah.
are there any medical management strategies that
Right.
we might use, in the meantime?
Well, beta blockers are sometimes used.
Yeah.
They can be helpful in managing things like angina
Mhm.
or controlling the heart rate, especially if there's atrial fibrillation, as in this case.
Right.
But it's really important to remember that medications are not a definitive treatment
Yeah.
for severe symptomatic aortic stenosis.
Right.
It's more about trying to just alleviate some of the symptoms while a more permanent solution like
Right.
valve replacement
Is being considered.
Got it. And then they also list a number of medications that should be avoided.
Yes.
So things like vasodilators, ACE inhibitors, nitrates, even sildenafil.
Right.
So why are those potentially harmful in someone with aortic stenosis?
Well, this is a really important point
Okay.
about managing aortic stenosis, and it's all to do with understanding that fine balance of blood flow.
Okay.
So all of those medications that you mentioned have the effect of widening the blood vessels,
Uh-huh.
which essentially lowers the systemic vascular resistance.
Okay.
Now, systemic vascular resistance is the pressure that the heart has to pump against.
Right.
Now, if you've got a fixed obstruction, like severe aortic stenosis,
Yeah.
where the heart's already struggling to push blood out,
Yeah.
if you then lower that resistance,
Right.
you can cause a big drop in blood pressure.
I see.
And that can worsen symptoms like dizziness, lightheadedness,
Okay.
or even fainting.
Right.
The heart simply can't increase its output enough.
To compensate for that sudden widening of the vessels.
I know.
And it can actually worsen that pressure gradient across the narrowed aortic valve.
Okay, so the heart's working against an obstruction. We don't want to make it harder
Exactly.
by reducing the pressure
That's right. Yeah.
on the other side of the bottleneck,
Yeah.
essentially.
Yeah.
Okay, so now let's talk about those surgical management options.
Sure.
So we've got mechanical aortic valves, tissue aortic valve replacements, and then TVI,
Yeah.
transcatheter aortic valve intervention.
Right.
So what are the key differences?
Well, the choice of which type of valve is best really depends on a whole host of individual patient factors.
Okay.
So, their age, their other medical problems, their lifestyle, their own preferences all come into play.
Okay.
Mechanical valves, these are made of durable materials. They tend to last a very long time,
Right.
often for the rest of the patient's life.
Right.
However, they do require lifelong anticoagulation with medication like warfarin to prevent blood clots from forming on that artificial surface.
I see.
Tissue valves, these are usually made from animal tissue.
Good.
They don't usually require that lifelong anticoagulation,
Okay.
which can be a huge advantage for some patients.
Right.
But they're not as durable
Oh,
as
wow.
mechanical valves.
Okay.
And they may need to be replaced at some point down the line.
Okay.
Now, TAVI, or transcatheter aortic valve implantation,
Right.
this is a minimally invasive procedure
Okay.
where you insert a new valve through a catheter,
Uh-huh.
which is usually put in through the groin.
Okay.
And this is often a very good option for patients who are deemed high risk
Right.
or not suitable for traditional open heart surgery.
Okay. Okay. And finally, they include this really helpful summary of the key clinical signs
Yeah.
that help us assess the severity of aortic stenosis.
Ab-
So things like the slow rising low volume pulse, that narrow pulse pressure, a quiet second heart sound, and then the characteristics of that murmur that we've been discussing.
Yeah.
So why don't you just briefly kind of reiterate why those findings are all so important to look at together?
Well, they're all really important because when you put them all together,
Yeah.
it paints a comprehensive picture of how severely narrow that aortic valve is
Right.
and how that's impacting on the heart's ability to pump blood.
Right.
So the slow rising low volume pulse, the
Yeah.
narrow pulse pressure, those are direct results of the reduced amount of blood being ejected with each heartbeat
Uh,
and the difficulty in generating a strong systolic pressure.
okay.
That muted or absent second heart sound,
Right.
as we said, strongly suggests that those valve leaflets are stiff and heavily calcified.
Right.
The high pitch, the long duration of that ejection systolic murmur, and
Yeah.
its radiation to the carotids, that all indicates significant turbulent blood flow across a severely narrowed valve.
Got it.
And although we didn't have a left ventricular heave in this particular case,
Right.
if it is present,
Yeah.
it can suggest that the left ventricles thick up significantly over time to try and compensate for that
Yeah.
increased workload.
Right. Right. And it's helpful too to contrast these findings with those of aortic regurgitation,
Right.
right, where the valve is leaky.
Yeah.
And we end up with a collapsing pulse, a wide pulse pressure,
Yep.
and then we're listening for a diastolic murmur instead.
Absolutely.
So a totally different set of physical findings
Yeah.
reflecting a very different kind of valve problem.
Exactly.
Okay, great. So to kind of bring it all together, this deep dive into these cardiology notes has really illuminated how aortic stenosis presents those key indicators we're looking for
Yeah.
to assess its severity, what other conditions we need to be thinking about,
Well,
and then the various approach to managing it.
right.
It really emphasizes the importance of recognizing that whole collection of signs,
Absolutely.
right, and then using further investigations
Yep.
to get a definitive diagnosis,
Right.
and then guide the best course of treatment.
Exactly. It emphasizes how that thorough physical examination
Yeah.
combined with strategically chosen investigations are really still the cornerstone of effectively diagnosing and managing this significant cardiac condition.
That's a fantastic overview, and it leads me to a final thought for you to consider.
Sure.
So given these different management options that we've talked about, mechanical valve,
Yeah.
tissue valve, TAVI,
Yep.
how might the presence of other significant health issues, maybe like a history of a stroke requiring someone to be on blood thinners, or a frailty that makes open heart surgery particularly risky,
Mm.
how might those things really influence that decision-making
Yeah.
process for a patient with symptomatic severe aortic stenosis?
It's such an important question, and it just highlights how personalized these decisions need to be,
Yeah.
especially when we're dealing with complex conditions like this.
Absolutely. Well, hey, thanks so much for joining me for this deep dive.
It's been a pleasure.
Until our next exploration.
Yeah, looking forward to it.
Take care.